high yield, neonatal GI issues.
Second White Coat. Subscribe and like. Let's learn medicine together.
Picture this. You're in the neonatal intensive care unit, and a newborn is vomiting. It's a high-stress, high-stakes situation. But before you start frantically running through a massive mental list of every possible diagnosis, you just need to stop and ask one single overarching question. Welcome to today's Explainer, where we're going to unlock the clinical mystery of diagnosing a vomiting newborn. And we're doing it using pure anatomy, not rote memorization. Let's dive in.
Here's our roadmap for today. We'll start with the core anatomical question, then move through early non-bilious obstructions, down into high and lower bilious blocks, and finally tie it all together with a master algorithm.
Section 1. The core anatomical question. Let's establish the absolute skeleton key that unlocks this entire diagnostic algorithm.
The question is simple. Is the vomit bilious or non-bilious? Basically, is it green or is it not? And the reason we ask this all comes down to knowing exactly where bile enters the gastrointestinal tract. You see, bile dumps into the GI tract at a very specific landmark. That's the major duodenal papilla, which is located right in the second portion of the duodenum.
This single anatomical landmark perfectly splits our diagnostic tree right in half. Think about it. If the structural obstruction occurs before that bile enters the duodenum, the vomit is usually going to be non-bilious. It's just stomach contents or milk. But if the obstruction happens after that point, the GI contents have already mixed with the bile. So as things back up, that green bile comes right back up too, giving you bilious vomiting. It literally is that simple.
Section 2. Non-bilious, the pyloric obstruction. Keeping that dividing line in mind, let's explore our first clinical presentation, focusing on blockages that happen very early in the digestive tract. Okay, consider this clinical mystery. We've got a 5-week-old boy who is incredibly hungry, but he's having progressively worsening projectile vomiting immediately after feeding. The absolute most crucial detail here, the vomit contains milk, but it is not green. It's non-bilious. Plus, a physical exam reveals a small, firm, olive-like mass in his upper abdomen. To solve this one, all you really have to do is follow the milk. The milk goes down the esophagus, into the stomach, and then it tries to pass through the pylorus to reach the duodenum. But in this baby's case, it hits a massive roadblock at the pylorus. Because the milk is thrown completely backward before it ever reaches the second portion of the duodenum, where that bile is sitting, the vomit is strictly non-bilious. So what we're looking at is the classic presentation of hypertrophic pyloric stenosis. The pyloric muscle has undergone severe hypertrophy. It's thickened so much that it creates a drastically narrowed outlet. The baby's stomach is contracting forcefully against this closed door, building up immense pressure until, bam, the gastric contents are forcefully and cleanly expelled. That's the projectile vomiting. And that thickened, hypertrophied muscle, that's exactly what you're feeling when you palpate that classic olive-shaped mass.
Moving on to Section 3, bilious, high intestinal obstructions. Let's see how the presentation changes as we cross our anatomical threshold and move past the bile duct into high bilious obstructions.
Here's our next case. A newborn with features of Down syndrome develops vomiting shortly after feeding. An abdominal X-ray reveals the classic double bubble sign. Now, because the obstruction here is past the major duodenal papilla, this baby is going to present with bilious, green vomiting. The diagnosis we're dealing with here is duodenal atresia. You see, during normal embryologic development, epithelial cells actually fill up the duodenal lumen. Later on, those cells are supposed to hollow out and reopen the tube, a process called recanalization. But if recanalization fails, the duodenum remains a closed blind loop, so everything backs up before the obstruction, creating exactly two distinct bubbles. The dilated stomach is bubble 1, and the dilated proximal duodenum is bubble 2. Now contrast that with this scenario. A newborn develops green, bilious vomiting and a terribly distended abdomen. They're rushed to surgery and the surgeon finds abnormal intestinal positioning along with these tight, fibrous structures called Ladd bands, extending from the cecum and crossing right over the duodenum. The crucial point here is this high-yield formula. Bilious vomiting plus Ladd bands equals malrotation. Normally, during fetal development, the midgut is supposed to complete this beautifully choreographed 270-degree counterclockwise rotation around the superior mesenteric artery, or SMA. Mal just means abnormal. If that rotation and fixation are incomplete, the bowel ends up sitting in the wrong place, the cecum is displaced, and those fibrous lad bands form across the duodenum, compressing it right from the outside and causing a severe obstruction.
Now, malrotation on its own is an obstruction, but it's actually a setup for a much deadlier complication, which is volvulus. Because the bowel didn't rotate properly, it has an abnormally narrow mesenteric base. Think of it like a top-heavy plant on a really thin, unstable stem. The midgut can easily twist around that narrow attachment, specifically twisting right around the SMA. This instantly cuts off the blood supply, leading to ischemia and necrosis of the bowel. Make no mistake, this is an absolute drop-everything surgical emergency.
All right, Section 4, bilious lower intestinal obstructions. We've covered the upper GI tract, so let's navigate further down the line to examine presentations where the structural obstruction happens much lower in the gut.
Consider this fascinating case. A 2-day-old newborn has bilious vomiting, abdominal distension, and crucially, a failure to pass meconium, which is their first stool. The physician performs a digital rectal exam and suddenly, there is an explosive release of trapped gas and stool. It's quite literally called the squirt sign.
This explosive presentation is the absolute hallmark of Hirschsprung disease. Here's the underlying pathophysiology. As a fetus develops, neural crest cells are supposed to migrate all the way down the bowel to become enteric ganglion cells, which are the cells that tell the bowel how to relax. In Hirschsprung, that migration stops prematurely, so the very distal end of the bowel has 0 ganglion cells. It literally cannot relax. It just stays tightly constricted. Meanwhile, the proximal bowel right above it dilates massively as stool piles up behind the roadblock. When you perform that rectal exam, you're manually temporarily forcing open that constricted outlet, allowing all that highly pressurized trapped gas and stool to forcefully escape.
Now, while our focus today relies heavily on our core conditions, you might occasionally see other anomalies disrupt the GI tract. There's Meckel's diverticulum, which presents with painless bleeding due to ectopic gastric acid, or jejunal atresia, where an intrauterine vascular accident causes missing, blind-ending small bowel. And then there's the annular pancreas, where an abnormal rotation forms a ring that physically squeezes the duodenum. But honestly, if you stick to the anatomical rules we've discussed today, you can deduce the location of almost any issue.
Section 5, the master algorithm. Let's look at how all these seemingly disparate pieces fit perfectly into one beautiful, cohesive framework.
Seriously, please stop memorizing endless lists of vomiting diseases. Rely on a clean anatomical map instead. Think about it. A 3 to 6 week old hungry baby with an olive mass. The obstruction is high up, the vomit is nonbilious, that's pyloric stenosis. If the vomit is bilious, you know the block is past the bile duct, so just look for your specific clue. See a double bubble? Duodenal atresia. Lad bands? Malrotation. Severe twisting around the SMA? Volvulus. An explosive exam after no meconium? Hirschsprung. The anatomy literally hands you the answer.
So the next time you're faced with a vomiting newborn, I want you to step back and ask yourself these 3 powerful questions. First, where does bile enter? Second, based on the color of the vomit, where must the obstruction be located? And finally, what physical finding or imaging clue tells me why that obstruction occurred? If you master the anatomy, you master the diagnosis. So what kind of medical mysteries will you decode next with this powerful anatomical framework in your toolkit? Thank you so much for exploring this explainer with us, and keep learning.